Good morning, everyone. Thank you for that introduction, Chris. I did ask my son what his one goal was in the London Marathon, and for those of you with sons who are fathers, there was only one goal, and that was to beat his dad, which he successfully accomplished by 10 minutes. I hope this is going to be a wonderful session, provocative. We have some experts on the panel, which I'll introduce briefly. And really what we want to dive into is essentially, I would like to sort of frame it and open it up a little bit about the profession of medicine as a whole, not just diagnostic imaging. We're here primarily focused on diagnostic imaging, and as you've seen from the title, it is machine learning and image analysis, a diagnostician's best friend or replacement, and we're certainly going to focus on that. But I sort of foresee that we're all going to be challenged in this space, not just radiology. I can even imagine primary care practitioners, potentially even now, being challenged in this space in terms of their value and worth as we move forward with AI. Already people are going online and putting their symptoms and signs into certain websites. And I could imagine a very sophisticated AI algorithm potentially diagnosing from the symptoms and now increasingly signs with monitors which you can place in the homes, etc., and then diagnosing particular conditions. And if you have an infection and you need antibiotics, how about Amazon sending a drone with the antibiotics, and so you never even need to leave the house. So I personally don't just see this as a diagnostic imaging issue. It's actually something we're going to have to grapple with as a whole in medicine. Just before moving forward, I sort of preamble in this whole technology space. I want to read you a quote. The substitution of machinery for human labor may render the population redundant. Now, I don't know whether any of you know where that quote came from, but it was written in 1821 with the mechanization of the weaving industry, particularly the spinning jenny, which came out of the UK and then completely transformed the weaving industry. And in the 1850s, all the weavers thought they were going to be out of jobs. The productivity for producing cloth increased 50 times. The cost per producing a yard of cloth decreased by 98%. But what actually happened was that the demand for cloth, because it could be produced so cheaply, rapidly increased. And between 1850 and 1890, the number of weavers in employment actually increased fourfold. Now, you can even go further back in history and look, and it turns out in Germany, in the 1470s, Augsburg, the wood engravers shut down the printing presses because they started to print illustrations amongst the text in books. Well, it turned out there was such a demand for illustrated books that the engravers' jobs dramatically increased, and they became vital to the growing number of illustrated and printed books. If we look at the last century, where there are many examples where automation and computer systems actually increase the jobs. And if you look at today, in fact, we're more fully employed than ever before, despite the automation and mechanization. Other examples from the last century, the ATMs. They thought that banking jobs would go, but in fact, the banks saved a lot of money through ATM machines, and so they could open more branches. Look at the airline industry. We can fly, all of you fly planes. You don't need a pilot, frankly, but there are more pilots employed today than ever before. So I'm going to leave here before asking the panel to introduce themselves. Is this different this time around? Is there something new and unique about artificial intelligence? The economic historians would say, no, this is just another new innovation and a new trend where it actually may create more jobs, albeit maybe different types of jobs. So with that, I'm going to ask our panel to introduce themselves briefly, to explore where they feel AI is going in the next 5 or 10 years, also just say very briefly about their interest in this particular area, and then address, if you will, this notion of friend or foe, both in radiology imaging and at times, if necessary, outside of our own specialty. And finally, I invite the audience to write in questions, which hopefully I'll get to in due course. Thank you.
Great. Well,
Andrew.
Thanks so much for putting together the panel and for including me. So my name is Andrew Beck. My background is trained as a physician. Initially thought I might just be a general practitioner, but focused very early on pathology, which for 150 years has been the specialty sort of assigned with mapping from a tissue sample to a diagnosis, and then that ground truth definitive diagnosis being a really key piece of information that's used to guide clinical care. And very early on in my training, I realized machine learning offers great potential for improving the ability of the specialty to map accurately from what's inside of a tissue sample and patient to a specific diagnosis. I did a PhD in machine learning prior to coming to Boston and starting a research lab in the Department of Pathology at Beth Israel Deaconess Medical Center. And over the past 5 years, while I've been doing research, I really saw firsthand the incredible advances in computer vision, cloud computing, as well as digital pathology, and really realized how this will be transformative for pathology for both the value it can bring to research and to drug development and to clinical trials, as well as to routine clinical care and routine types of diagnoses. And there's a lot of the key technological components that are so central to this specialty, which is really all about information processing from tissue to diagnosis. So I'm very passionate about the ability of the recent advances in AI and technology to transform the field of pathology, and that should bring lots of value to patients and throughout all of medicine, just because pathologic diagnoses are so critical. And in terms of the friend or foe question, I mean, first, I think it's sort of a misnomer question. I think without a doubt, this is on the friend side, and a really powerful technology that it's not even a friend in the sense that it's autonomous enough to solve this by itself. It really needs the investment and the training of the medical profession to really leverage this as best we can to address the most core topics in medicine. And the types of problems were really what brought us all into medicine that we're interested in solving are really hard and big, and we're very far from being able to effectively solve them, even with the AI of today. So I think there's an enormous number of problems to solve, an enormous amount of work that we still need to do, and we're very lucky that we have this access to these new technologies that should really assist the profession in being more effective.
Thank you. Dorin.
Thank you. My name is Dorin Comaniciu. I'm very, very pleased to be here. My background is in machine learning and in statistics. My first job with Siemens was in automotive industry for self-driving cars. And since quite a couple of years, I'm focusing on medical imaging, on healthcare for Siemens. So artificial intelligence has evolved in a fascinating way for the last couple of years. The more data, the better the performance, the promise of performance with very, very low error. So having said that, there is a lot of optimism to apply artificial intelligence at multiple levels, at the scanner level, higher at the processing data, at the post-processing, at the level of diagnosis, of intervention. And then the next level comes integrating data around the patient, talking about precision, about predicting, about prescribing what is the best for this patient at this moment of time, meaning expanding precision medicine. And then the next level goes into the population health and outcome analysis. So there is a lot of excitement in the field, but there are also many, many challenges. My point is always, right, that we have to deliver systems that perform according to specifications. And when I'm looking at radiology specifically, there is the topic of incidentals. I believe that radiology findings, and there's a lot of statistics out there, are structured in the long tail distribution. While AI can solve today quite a bit for the very, very often encountered cases, there is the long tail, the incidentals, which are very challenging. So I would say that there will be an evolution. I would say that AI will certainly benefit quite a number of topics. And starting with increasing efficiency, doing what matters for patients, and ultimately pushing forward precision medicine. At the same time, we'll have to work together from a technology, clinicians, and ultimately patients to do things that ultimately matter.
Thank you, Dorin. Eyal.
Hi, everyone. Happy to be here. So my name is Eyal Gura. I'm a co-founder of a little startup out of a tiny kibbutz in Israel called Zebra Medical Vision. We started this journey early on. Personally, it's a 7-year journey for me now. We did much of a heavy lifting in the first 3 years to aggregate an immense a lot of data so we can tackle the problem of how to teach computers to read medical imaging scans. And we partnered with very large HMO groups that have longitudinal data and patient outcomes so that we can feed the machines millions and millions of medical imaging studies and gradually teach them how to read it. It's always a bit funny for me to be on those panels because it's very humbling. I don't have any PhD or AI qualification, and I'm not a doctor. So it's also very exciting for me to see the mind shift from where we started 7 years ago, where I went to conferences and people just told me, this is stupid, you shouldn't even start it. Then a few years later, it's not so stupid, but you should know that those things were tested in the academia for many years, and all of them failed, and CAD failed, and you should never try it. And to the extent that now we have hallways full with people that want to contribute to this revolution and to join, and it's very exciting on a personal level. In terms of what we actually achieved with in ZebraMed, by the end of this year, we'll probably have more than 30 AI products. Each one of them know how to diagnose or identify a specific condition in multiple modalities. So we have algorithms for CT scans, mammograms, X-rays, and gradually we'll add more modalities like MRIs and ultrasounds. And it's very exciting to see the results. We'll discuss it later, both from real-time decision support, but also from a population health management and predictive analytics. And in terms of friends or foe, we always get this question. For me, it's a very clear answer. It will be the same like the other professions that were cited before. And there are not enough radiologists or pathologists worldwide. And if you count the number of existing universities and the ones that are being built and the number of teaching professors, you realize that as humankind, we are not equipped to deal with the 2 billion people that are joining middle class and the aging population. So radiologists and pathologists will have 10x more work to do, and hopefully AI will help them to do it 100x better. So that's my view.
Thank you. Karim.
Good morning. My name is Karim Karti. I'm with G Healthcare. I lead the imaging business. And thanks again for the invitation to speak here. This has been just a wonderful 2 days learning about what all the industries within healthcare are doing, and I think it's extremely exciting. So on your first question around, is this a passing trend or is this something pretty profound? My humble opinion is this is a very transformational technology that's coming into healthcare. And I'll give a little bit of an anecdote based on one of the things that I like to do from time to time, which is to play chess. So I don't know if you followed, in December, a few months ago, they had DeepMind actually put together chess software that played against the most powerful chess computer, which was Stockfish. And many of you know, 10 years ago in chess, the computers already beat the humans with Stockfish. However, interestingly, a few months ago, they put a new computer, a new algorithm based on both reinforcement learning and deep learning. And that algorithm was put together with a very different approach. That algorithm learned to play against itself in few hours. And then they had that computer play against the best computer in the world, which, by the way, is better than any human. Guess, what was the score over 100 games? Well, basically, the new computer, Alpha Chess, won the whole contest. Stockfish could not beat one time Alpha Chess, which was absolutely incredible. Think about this. The computer learned against itself in a few hours. The most interesting things about this is, and this is based on the comment of Garry Kasparov, which is obviously one of the best chess players of all times, is one of the things they've observed is the way this new algorithm played, which was completely different from anything they have seen before. And it played in a very untraditional way that people thought was not possible. Very aggressive plays, very, playing sacrifices that people did not think about. And this, what does this tell us? This tells us that we thought that maybe AI can match, human cognitive abilities. Well, maybe this has the potential to pass human cognitive abilities. So clearly, when you see a technology like this that can look not only at recognizing patterns that maybe we see, it might see things that we can't see. And so I think this is really transformational, Giles. Now, when you look at this technology now in our field in healthcare, is it a friend or foe? I would say, number one, just looking at our own business, we build scanners. And, I'll do the analogy with vehicles that you heard from Jensen yesterday. We have the same ambition, which is to build intelligent scanners, like the industry in cars is building intelligent cars. This doesn't mean that, the machines are going to do all the job, but there is plenty of opportunities for our scanners to be used in a faster way, in an easier way. It is very complicated to use some of our machines, as many of you know. There is a lack of technicians. The images that we provide today do not have quantitation, do not have enough processed information. It's mostly an image. The future can be an image and data associated with both of the scanners. So the vision here is that we can help the whole healthcare community and the radiologists make these machines a lot more intelligent and a lot more useful. So we think this technology is going to be a great friend for the whole healthcare community and the radiologist community.
Thank you, Connie.
Yes, delighted to be here. These days have been a highlight of the year for sure. The shared vision and the goals that we all have has been exciting. So I'm Connie Lehman. I'm Division Chief of Breast Imaging at Mass General and Professor of Radiology at Harvard. And when I first came into medicine, I was getting my MD and PhD in psychology, and I was fascinated in human behaviors and what drives decision-making, and also in human health. And I, much to the surprise of many of my mentors, selected the imaging sciences as my area of expertise because I felt the tools in imaging sciences were unparalleled to really impact human health. And then selected breast imaging because of the extraordinary opportunity to impact a very significant disease worldwide, breast cancer. So the last 20 years of my career have been tackling breast cancer in multiple different areas, globally with ultrasound programs in Africa and other parts of the world, seeing the challenges to heroic efforts that my teams and others around the world have been making, but without the impact that we wanted. And then nationally, studies on MRI and tomosynthesis and screening mammography, the fantastic advances that have been made in the imaging sciences, but with extreme challenges due to variation in quality and in limitations in access. And then locally at my center where I came from in Seattle at Fred Hutch and the University of Washington on improving the patient care experience. How can we provide high quality at low cost and engaging patients in needed care? So then when I had this opportunity to transition about 2 or 3 years ago to MGH in Boston, I didn't realize how important that decision would be until I arrived. I knew that MGH and partners and the Boston community was enticing. I knew this is where change agents came. I knew this is where incredible advances were being made. But I didn't know that a radiation oncologist, Alphonse Tagian at MGH, would introduce me to one of his patients who had just gone through her breast cancer treatment in her early 40s at MGH. And that was Dr. Regina Barzilay, a professor of computer science at MIT. And Regina, after going through her treatment, realized that the work she had been doing in artificial intelligence and computer science had been applied to areas and topics that weren't as compelling to her as breast cancer and cancer care. And so she shifted her focus and that of her labs over to tackling a really personal and very important problem that she was facing in breast cancer. So we started working together and we've made inroads into the face of breast cancer. We're fully engaged to change that. We clearly see AI as a friend. It is going to allow us to have an impact on patient care at a level that previously was unimaginable. And as far as the jobs and how are people feeling about this, I think there's great news that the more and more I talk to radiologists, the more excited they are about living in this time where we can finally have the impact that we've wanted to have on our patients because we have new tools available and new partners available that we haven't had before. So I'm excited about the discussion we're going to have and happy to be here.
Thank you. Connie, let me just pick up on that because I'll speak for radiologists and there may be some pathologists in the room because I think many of the conversations we're having will be germane to pathology as well as it transitions over to digital slide platforms. Given that we are almost completely digital in radiology, at least from the imaging, interpretation, perception point of view, we've had a bad rap, as you're probably aware. If you look around the press, the one medical specialty that people point fingers at is radiology, saying that we're going to go out of business. Now, interestingly, back in 2005, when Thomas Friedman wrote his book, The World is Flat, he kind of said the same thing, at least for US radiologists. He said because of outsourcing of these digital platforms to India, et cetera, that he quoted, he said, I would not want to be a radiologist. Well, it turns out that the job market for radiology at the moment is better than it's ever been. There's more radiologists in the US, and hopefully they're creating even more value. But I want to sort of just dig down a little deeper because it is the focus of this session is, it's all very well saying it's going to help us, but how? And are there going to be less radiologists and potentially pathologists? Are there going to be more? And what's the interplay and role between the machines and the providers? Andrew.
No, I think it's a great question. I think in concept, it is thinking about radiology, like what defines radiology? What's the mission of the field? And how do they want to choose to bring value to patients? And I think like those questions, certain aspects AI will help a lot, and others it may not be relevant. And I think radiology has actually been, I'm not a radiologist, but a very innovative field in becoming different over time. And there's things like interventional radiology that certain radiologists do exclusively that they wouldn't have imagined, I don't think, 30 years ago. So I think it's the onus of the medical profession to not sort of think of this technology as some external friend or foe, but just like one additional tool, and how do we want to bring value to medicine. And I think if people aren't innovative and creative in doing that, I mean, there is a world where if you're focusing on low-level tasks that a computer can do better than a human, and that's the only value you bring, maybe you will be out of a job. I mean, I just think we need to be open about that possibility. But if your goal is, bring value in medicine and creative ways of utilizing tools and solving the newest problems in the future, I think radiology and pathology, you will see them being the most sophisticated users and developers and applying this technology to the problems that are going to be of most value to patients. And I think if one views the problem that way, how can we best utilize these tools? Because the truth is there are so many simple problems that the technology needs to be adapted and built and value needs to be shown to be utilized. So we're so far from a replacement even today. And I think it's the mindset of how can we best use these tools to bring value to patients. And I think the job will definitely change 30 years from now. I would hope both a radiologist and a pathologist will be bringing even more value to medicine. I think we will need even more of them, mainly because the therapeutic space is becoming so much more complicated and there's so many more choices to be made that radiology, very similar to pathology, is a task of how do we integrate all of this heterogeneous input data, which is partly image, partly history, partly scans over time, partly patient preference or physician preference, into the best recommendation for clinical care. And those sets of challenges are really hard. And I would imagine, the work of a radiologist in 30 years and a pathologist will look very different, but they'll be even more required than today, where the input space is relatively simpler. And certainly the therapeutic options, I think, are far more limited than they will be in the future.
Great. Other comments?
So this is a very interesting question. So first of all, AI is among us, right? So for radiology, our main reading platform is being used 500,000 times per week, and it's loaded with a lot of AI algorithms, right? The question is that how things are evolving from here. My perception is that scanners are becoming more intelligent. Intelligent from the point of view of acquisition, from a reconstruction, from doing things automatically. So that's number one. Number two, on the processing, on the post-processing side, there are so many exciting projects, and we heard here of many, and you're starting with, and it has been mentioned here, with measurements, with parsing the data, and going to more specifics, say, meaningful projects on prostate, on fusing the anatomical and functional information and together with pathology to detect in a precise way lesions, malignant lesions for prostate, and ultimately in the hope that would save biopsies, which is a major patient impact. And we also asked the question, how far can we go, right? So we took a case, chest CT, right? So now chest CT, typically the discussion is about detecting lung nodules. But then we took the system further to detect lung nodules, but also to look for emphysema, to look for calcium scoring, to measure the dimensions of the heart, to measure the dimensions of the aorta, to look for calcifications in the aorta, to look for bone mineral density, look at the airways, and look for the vertebra fractures, and so on and so forth. So now you have a system that at some point might run on the scanner that pretty much provides the radiologist with all these findings and incidentals. And we see that coming, right? Now, moving forward, right, to me, the most exciting part is what can be done towards precision medicine. So our CEO, Bermontar, talked a little bit yesterday about our digital twin. And just to give you a simple example, we have a very interesting model of the heart. So our scientists actually, they built my heart, right? They rebuild it. So it's a model that is a physiological model that beats like my heart, that has the same ejection fraction, so the same electrical signal propagation, the same biomechanics. But in addition to that, that model is under our control. So which means that we can start testing therapies, and we do that in a couple of clinics. And this is fascinating, right? Because when we extrapolate once more, we see such models kind of following us through life. right? It's a digital twin. It's a physiological model following us through life and gradually integrating more and more information about us, right? And from here, one can move not only to the disease care, the way entire medicine is about today, but to health care, right? And this is a very, very interesting development that I believe that AI can bring to us. Yeah? Thank you.
Thank you.
I totally agree about finding all those incidentals and other things that typically radiologists will not look for in the first place. Specifically, we saw recently 2 interesting cases in population health management, one predicting cardiac events based on automated calcium scoring in regular traditional CT scans. And the other one is the ability to predict osteoporosis fractures and actually beating what's called the FRAX index just by taking a look on a regular CT scan and running few of our bone health algorithms. And we did it on like 50,000 patients, 5 years type of research that we were able to do with our HMO partners. So our team was just in an osteoporosis event in Krakow, the global osteoporosis event, and there were almost no radiologists over there, but all the leading heads of the FLS, the fracture liaison services, they say, how can we identify more fractures? How can we enroll people earlier to prevention programs? And we now know the answers, that radiologists will be able to serve better many other departments within the hospital. The bone health department will get from the many leads that they didn't get otherwise. The pulmonary department will get referrals of people that have mild emphysema levels and usually no one will bother to do anything with them. And the cardiac department will get more and more leads of people that are about to get a cardiac event. And so I see a truly exciting trend of how radiologists can add more and more value using AI.
I want to get to some other questions and then questions to the audience, and maybe start the other end. Connie, come back this way. I think this is germane to many physicians in the room, or at least providers, is the issue of burnout. And it's sort of the zeitgeist right now in medicine is, it seems half our employees are burnt out. In radiology, it's about 40%. They're saying the workload is huge. There's a lot of repetitive work. There's a lot of screening work. Typical MRI nowadays can have 2,500 images to look at. Connie, can you give us an idea potentially how AI can address the burnout issue, not just for radiology, but potentially for other specialties as well? And then others, please join in.
Yeah, absolutely. It's a great question. So I always think of AI, and with my faculty as we talk about it, it's like having this fantastic basket of tools, and we can reach in for the different problems that we face and our patients face, and we can pull out a different tool and solve that problem in a way we never were able to before. So the burnout, the repetitive tasks, the not working at the top of your license, the feeling that you're scribes or you're running around just trying to find the data on your patient so you can have the most effective diagnosis possible. We have tools that we can pull out to enhance the quality of our work and what we do. And just as a very concrete example, every day at 4:30 at MGH, we do something called our RAD-PATH conference, and we sit around in a team huddle, and we look at the pathology that's coming in from our pathologist, and we look at the imaging, and we decide if that's concordant and what our recommendation is to the patient. Now, the way we've always done that is we look at the histology. If it's atypical ductal hyperplasia, we recommend they go to the operating room to have that surgically excised because of a small but real risk that there is cancer at that area where the ADH is. There are other kinds of high-risk lesions, and we send those to the operating room as well. And we have discussions, but it is on extremely limited data. So with Regina and her team at MIT, we developed a new model. We could take 20,000 variables out of the patients that had come through MGH day after day after day at those RAD-PATHs. We could take those variables and create a model that could be much more precise, much more targeted, much more personalized. Does that woman need that surgery or not? And reduce unnecessary surgeries by a third with a very simple model. And we're continuing to iterate on that. Our workflow is different. It's more interesting. It's more exciting. We have every screening mammogram. We do 50,000 a year. Every one is pulled out of PACS, processed through the deep learning network that we have, automatically assigned a breast density. This is a subjective measure that radiologists vary enormously in assessing breast density. The machine learning model does that, presents it to the radiologist who accepts or rejects it, along with a full report of that screening mammogram, which allows us to improve our efficiency, operate at extremely high level of productivity, but in a much less stressful way, more organized way. And those are just a few examples. So we've recruited some recent faculty from all over the country, from Duke and Johns Hopkins and Mayo Clinic, and they are so excited because this is the future, this is the new way of delivering care to our patients with tools now that they just wouldn't have other places or don't have yet, but they will soon.
I totally agree with Connie. And, going back to your comment on the, hey, the job market is great. We manufacturers, we're making it great because, the past 10 years, we have kept, growing the technology. And, what we used to be a few images, now it's hundreds and thousands of images per study. So imagine the workload for radiologists. I'm not sure, by the way, that people are really afraid. People are looking for solutions right now to deal with the workload. Most of the people have piles and piles of images that they can't keep up with. So clearly there is an opportunity here. And if you think about an example, if you look at the PET-CT field and oncology, so most of a huge amount of patients are follow-up patients, metastatic patients, right? When radiologists are in front of their screens in the reading room, they have to call up all the priors, and they have to go and look for every single lesion and look at the progression of every single lesion, go and look up for every data on the EMR, look at the history. Some of these cases, they don't take 5 minutes to read. They take a long, long time. We can automate this in a very easy way. This is not, I would say trying to come up with, the next best way to predict how the tumors are going to grow, but this is simplifying the workload. What does that allow the radiologist to do? Then the radiologist can move from being in the reading room to become part of a multidisciplinary team that will participate in the decision of care for the patient, exactly what Connie has mentioned. And I think that's the future. The future is potentially less reading rooms, more radiologists out there in each of the departments, working with multidisciplinary teams in their areas.
Thank you. I want to get to some questions from the audience. And here's one that radiologists have often been criticized for sort of creating the value where imaging just keeps growing and growing and growing, and it's affecting costs and et cetera. So with AI, if interpreting images becomes faster and easier, how do we prevent a growth of inappropriate or potentially harmful scans? Dorin.
Go ahead.
Please, go ahead.
Well, I love that question because we have, again and again and again, the story of overutilization, underutilization. So I did research in breast MRI, was so excited about this technology, the most sensitive tool we have for finding cancer. We did a large national study that showed that over half of the women undergoing breast MRI should not be getting the breast MRI, do not meet the indications that would make that an appropriate test. And then we flipped it and said, of those women who are extremely high risk, how many have ever had a breast MRI? It was 2%. And so what we need to do, and what we have tools with AI to do, how can we go into medical records, how can we go into information and pull out the patients that do need those tests, engage them, and ensure that we don't have the unnecessary tests being performed where it doesn't provide added value and it significantly increases our costs.
Dorin, you had a comment?
Yes, so I like very much a comment from yesterday that AI is perhaps the only technology that has the promise to give more access to healthcare, to reduce the cost, and to increase the quality. And so now when you think of the radiology workflow, and Karim, you mentioned the example of chess, right? I believe that everything that can be isolated as a task can be, and which is part of a high throughput data flow, that part can be automated with very high precision, right? So the question is that how the radiology workflow adapts to benefit from these smart agents that I believe we'll see more and more as a part of the reading. But more than that, having smart agents doesn't mean only doing what we do today. We have to think what is the opportunity for the future. So for example, we have a very interesting network. It's called Deep Reasoner that has the capability to summarize patient data and also make predictions. Now imagine that a radiologist would have such networks on their own desk to use such prediction while one's doing reading, while integrating with EMR, and so on and so forth. So I heard from MGH, from Harvard, the term that the radiologist is transforming into a shepherd of data. And I believe that. I believe that there will be more and more intelligent management of data coming from multiple sources at the radiologist's desk.
Just to, we can look also at the problem another way, which is imaging has the potential also to reduce the cost of unnecessary therapies, as opposed to just look at, too much imaging. Look at the mass majority of the cost comes from the cost of therapy in the healthcare system. And, there are multiple ways that we can better diagnose and better predict whether the therapy is going to work or not and avoid administering the wrong therapy. So an example, a very simple one, is recently a company called HeartFlow is doing on CT, basically simulating what we can do in the cath lab and being able to send a patient to the cath lab to stent them. That's a major, cost avoidance. When the future, and we're looking at that right now, is the cost of immunotherapy is extremely high. Can we look at which patients will be able to respond and not respond and avoid dramatic costs? So imaging has also the opportunity to significantly lower the costs in the healthcare system.
Two more places where we might want to put the light on is like acute care. So sometimes, even before the image scan gets to a radiologist, there is value that can be created just based on speed. So we talked earlier about the chess players and how quickly they learn. But if there is a case of pneumothorax or brain bleed or aneurysm, sometimes it's very valuable just to push this case up in the work list and make sure someone gets to it first, and then show it to a human being to make a decision. But those seconds are very crucial. The other case is the geographical distribution of expertise. So half of the world population live in radiologist and pathologist deprived areas. And there are only like 50 radiologists that are treating the entire 270 million people in Nigeria, and we have similar cases in other areas in Africa. And over there, even the radiologists that are trained, their experience is based on reading chest X-rays in the last 5 or 10 years. They don't know how to read CT. They don't know how to read MRI. And AI can really help with the training and advice to those radiologists.
Thank you. I want to get to, in fact, one of the questions which I think you've just answered there was, given the global shortage of radiologists and pathologists, how might AI transform access to care in the developing world? But I want to move on to this interesting question for those in the diagnostic specialties in the room. Will pathology and radiology merge as the specialties converge into an ML-powered diagnostic specialty? Andrew.
No, I think it's a really exciting question. I think we could see that in the future. I mean, I think that both of them are information processing specialties. I mean, they have very different, reading rooms, as we heard earlier today, and they're kind of siloed to some degree in different reading rooms, and even just interoperability to make it efficient for pathologists to be able to review the radiology and to use that information to interpret the tissue is difficult today. But I could definitely see in the future a real synergy because each data type has information that the other doesn't. And they have really the same core mission, which is how do you guide therapeutic decisions based on diagnostic data. So we'll have to see how the field's evolved. It's not going to happen by itself. I mean, I think there will need to be leadership within pathology and radiology who really come together and see the benefits of that. And pathology works at the molecular and cellular scale typically, and radiology works more at the organ and tissue scale, and radiology uses the advantage of images and data over time, whereas pathology is usually more limited to a single point in time. So clearly there's real synergies among those data types, and I certainly hope in the future we see much tighter integration, and potentially there will just be a diagnostic information specialist that is very comfortable with working from the radiology scale all the way down to the pathology scale.
Okay.
Yeah, I think, you know, Giles, I think that the bigger question is how do you do better diagnosis, integrating the multiple data that we have around the patient. So it might not be just about pathology and radiology, but how do you get the genomics data? How do you get all the other data that is available at the, you know, on the patient? And frankly, this is one of the things that you know, we're working on is building platforms that enable, you know, the clinicians to access very easily that data and make sense out of it. And this goes back to the discussion we had and we heard from, you know, on the first day. How do you make things easier for the physicians and for the patients? Today, the patient, you know, not many things have changed for the patient. You still go to the doctor, you have a written report, you know, you're waiting for the, can we give to the patient a digital report? And can that digital report be also the report that the radiologist or anybody who does the diagnostic has all the data? If we make those two happen, then there is maybe a big opportunity for change.
I have another quick question, if I may, Dorin, because we almost running out of time here. And there are many good questions here. We could go on for a long time. Most AI systems contain neural network components whose expertise is hidden in vast layers of internodal weights and bias factors. It works great, but doesn't teach us. How do we get AI to teach us? And a corollary sort of point is the notion, the new sort of emerging field of explainable artificial intelligence. And the EU, in fact, has got a law on the books to pass this year. Unless we can get inside those neural networks and help explain their outputs, how they come up with the algorithms, they won't necessarily be able to be implemented into whatever field they're looking into, and particularly medicine. So just very briefly, any comments on this notion of we can get great outputs, but how do we trust them?
So one quick kind of unique advantage, I think, of image-based deep learning is it's all supervised learning with deep convolutional neural nets and things. So for example, in pathology, and what we do a lot of at PathAI is we can train the computer to understand and put a name on every single cell and every single slide. Is it a lymphocyte? Is it a macrophage? Is it a tumor cell? Where is it located? Is it pre-treatment or post-treatment? So we can use deep learning and these black box approaches to generate very rich, quantitative, interpretable data sets to answer very specific questions with a yes or a no based on data. So in a way, it's the technology enables you to convert this totally unstructured, very difficult to interpret data into a very human interpretable, clean set of data that can be used to answer very specific questions. So I actually think, and we don't really care what's going on the inside of the model for the task of finding cells and finding nuclei. I think something similar could be done in radiology. So it's a lot of how these technologies are used, and they can be used in certain ways where the results can be very interpretable and allow you to make data-driven decisions.
Dorin, briefly.
I believe that the problems that we deal with today are beyond explanatory, meaning explicit equations. We are addressing very complex problems. And just to give you one short example, the data integration that we mentioned here, from the genomic level to molecular to diagnostic to imaging, we have networks that are creating task-specific patient fingerprints that are designed to make predictions for specific cardiovascular event, for response to drug therapy, and so on and so forth. Those are very difficult problems to explain in equations. So I agree very much on the term of testing, on validation, and so on.
Well, unfortunately, regrettably, at least for me, and probably I'm biased because of the subject matter, we've run out of time. And I do want to thank the audience. There are many, many great questions in here. I've got about 20 questions I never got to. For instance, if AI reduces the workload, increases the efficiency for providers, will that lead to reduced payment to the providers? There's a thorny one right there. But with that, I would like to sincerely thank the panel for their input and for their insights, and we'll see where this goes. I guess the ultimate question is, if your kids are wanting to go into medicine and they're saying, shall I go into radiology pathology? We'll leave it as an open question. Would you advise them to do so? Thank you very much.